Thank you very much. It's really refreshing to be in a room full of people who have very similar stories to yourself. Sometimes when you're working as a clinician in isolation, you do begin to wonder whether you're doing the right thing. And actually, I felt really reassured this morning that everybody seems to have the same kinds of dilemmas that I have when I'm seeing patients, and that taking a holistic view seems to me to be the crux to a lot of this. So what I'm going to do over the next quarter of an hour is just run through fatigue and PoTS. For those of you that know me, you'll know that I'm particularly interested in autonomic dysfunction and the role that that has in the pathophysiology of fatigue, in chronic fatigue syndrome and in other chronic diseases, including PoTS. And I'm going to finish off with just a little bit about the approach that we have in the clinic in Newcastle. So for those of you who are seeing patients with PoTS, you'll recognise the descriptions of fatigue that are here on this slide. It's a very significant symptom in patients with PoTS, and we'll come on to describe in the next few slides the prevalence in PoTS and the overlap with chronic fatigue syndrome. But it's a very common symptom in a range of different chronic diseases. And for any of you who are GPs, it's actually the bulk of the work that you do in general practice. 25% of consultations in primary care involve the symptom of fatigue, and 6.5% it's the main reason why people will go and see their GP. So it's a huge burden not only for the individual but also for our healthcare system. And what might be the reason why people with PoTS are more likely to describe fatigue? Well, it may be that it's something, a phenomena, a symptom that is specific to PoTS itself, but it may be that it's related to this overlap that we've heard so much about this morning with joint hypermobility and heads. It may also be that perhaps there's an overlap with chronic fatigue syndrome, which I'll talk about a little bit more in subsequent slides. We've heard about the different medications that we might choose to use in people with PoTS, and some of them, as we've heard, like beta blockers, are specifically associated with fatigue. And some of the medicines that we use that drop your blood pressure, we know will actually make people feel significantly more symptomatic from fatigue. So it may be in some way related to that. It's been great this morning hearing so much about sleep, because in my clinical practice, we're increasingly recognising the problems with sleep that patients with PoTS will describe. And it may be, as in other fatigue-associated chronic diseases, that there is an overlap or an abnormality of sleep disturbance that may actually be part of the fundamental pathophysiology of fatigue in PoTS. And all in all, it may be that the symptoms that patients with PoTS experience are related to all of those things in somebody who has had their lives completely destroyed by a condition that has stopped them doing the things that they wanted to do, stopped them going to school, stopped them being able to live their normal life. So an individual who is trying to continue to manage, perhaps doing all those things that they want or need to do in their life, and struggling while extremely symptomatic. So in terms of chronic fatigue syndrome, known by many as ME, importantly, chronic fatigue syndrome is a constellation of symptoms that are recognised under a variety of different diagnostic criteria. In the UK, the CFS clinical services that are that previously were throughout the NHS but are now becoming more and more in pockets use what's called the FUKUDA diagnostic criteria. And that's simply a tick box format whereby you do or you do not have a constellation or cluster of symptoms that mean that you do or do not fulfil the diagnostic criteria. But CFS is a physiological illness that is recognised by the World Health Organization as a neurological disorder. And it is covered by the Disability Discrimination Act, which has some advantages for people in terms of the diagnosis. We know at the moment that CFSME is medically unexplained, but there is a huge amount of literature that is in existence and continuing to emerge that identifies a whole range of physiological and immunological abnormalities that are present in those with CFSME. But as you'll know, at the present time, we have no therapies above and beyond graded exercise therapy and cognitive behavioural therapy in CFSME. So CFSME, as I've said, is a condition that is a cluster of symptoms. There are no pointers towards the diagnosis above and beyond those symptomatic descriptions. And in patients that you might see in clinic, they have normal blood tests and a normal examination. But I like to think about CFSME, as we've heard before, as obviously a syndrome, but it's an umbrella diagnosis. It's a heterogeneous condition. And if you see people in clinic with CFSME, you'll begin to recognise that there are different types of CFS. So I consider it to be an umbrella diagnosis, whereby underneath it there are a whole range of different conditions that are lumped together as this diagnosis of CFSME. And that if we begin to understand the different conditions that are underneath that umbrella, in CFSME, we can begin to develop specific phenotypically driven treatments. And what I think is that PoTS is one of those conditions that historically has been lumped underneath that umbrella, and that as we begin to understand more about PoTS, those with CFSME who've been labelled with that diagnosis in the past will begin to get more and appropriate treatments for their PoTS. So CFSME is actually quite a common condition. It accounts for about 0.2 to 0.4% prevalence, and the figures there for each general practice. So it affects about 4,000 cases per million population. And we've done research in Newcastle whereby we've performed tilt table testing in patients with CFSME as part of our work trying to understand the role of autonomic dysfunction in CFSME. So we've done tilt table tests, and if people haven't seen this instrument of torture before, it's a mechanical bed that brings you to standing in a consistent, structured way and allows you to look at the physiological response to orthostasis. So using continuous heart rate and blood pressure, and we use a system called the task force, it allows you to look at very subtle changes in heart rate and blood pressure continuously. And a study that we did a number of years ago where we took a cohort of patients with CFS-ME, so 64 patients and 64 controls matched for age, sex and activity levels. The important line is the line at the bottom. What we were able to show was that when people with the diagnosis of CFS-ME are actually tested properly for a diagnosis of PoTS, then CFSME patients, almost a third of them will have a diagnosis of PoTS. So as I've said, in terms of diagnosing CFSME in PoTS populations, this is the NICE guidelines website. So in the UK, NICE is the organisation that gives us our guidelines that we follow in clinical practice, and there are CFS NICE guidelines. This is just showing you the cluster of symptoms that you need to tick a box for the diagnosis of CFS. And if we want to consider how much of an overlap there is between PoTS and CFS, this is the survey that was carried out by PoTS UK that you've heard about earlier in this morning. And this is a survey of over 700 patients in the UK who are members of PoTS UK who've been diagnosed with PoTS by their GP or by a specialist. And as you can see in the greeny blue box, a significant proportion of those responding have a comorbid diagnosis of chronic fatigue syndrome. So that just explains again the methodology by which we got hold of the results from the patients. It was deployed by PoTS UK, And we had a response from, as I said, over 700 patients who have a specialist diagnosis or a GP diagnosis. The demographics of that population were, as you might expect, predominantly female, predominantly young to middle-aged. Interestingly, for the purposes of today, 91% of those who responded described having significant fatigue. But interestingly for me, as a falls and syncope doctor, nearly 60% of them also described a history of syncope and blackouts. In our clinical practice, as I've said, we use continuous heart rate and blood pressure, and everybody who comes to my fatigue clinic will have an active stand so that we can look for a diagnosis of PoTS, and this is the task force monitor that's measuring heart rate and blood pressure from your fingers. And in terms of diagnosing autonomic dysfunction in the patients that we see in the fatigue clinic, we will always perform additional testing in people who describe a history of syncope, which is actually, as we've seen, very common in patients with PoTS, and it's very common in patients with fatigue. And we'll also perform additional testing in fatigued patients who describe a very postural element to their symptoms. We'll also think about doing additional testing, so do formal tilt testing or additional Holter monitoring in patients who describe symptoms where physiologically you are suspicious that they may be dropping their blood pressure. So if they're very symptomatic after meals, showers, getting in the bath, etc. Just wanted to show you a little bit about a bit more about sleep. We ask everybody who comes to our clinic to do a sleep diary. So that's 2 weeks of a sort of semi-quantitative assessment of their sleep. And these are just a very short snapshot of a small cohort of PoTS patients who've been to the fatigue clinic, where we've asked them to quantify their sleep for us. And looking at a range of different quantitative sleep parameters derived from these 2-week sleep diaries, you can see the scores are the Epworth Sleepiness Scale, the ESS, which is a measure of daytime sleepiness, and the OGS, which is a measure of orthostatic intolerance, both tools that we use routinely in the fatigue clinic. And you can see that there are relationships between the symptoms that people are experiencing and parameters that we can quantify from their sleep diaries, suggesting that sleep does play quite a significant part in the symptoms that people are experiencing. So in terms of Newcastle and what we do with our patients, we don't have a dedicated PoTS clinic. There are some PoTS patients who come to see us in the falls and syncope service, but I have a dedicated fatigue clinic on a Monday morning, which is called a Cresta Clinic, which is a very, very long acronym, which you'll see there. So I don't know who thought that up, but Cresta sounds much better. We started that in 2013 and have seen nearly 1,000 patients there with fatigue in association with chronic disease, so not chronic fatigue syndrome patients. There's a whole separate service for that in Newcastle. And in that service, we see patients with PoTS where fatigue is a significant problem. I'm really proud of the fact that when we first set the clinic up, it was awarded the Service Improvement Award for our NHS Innovations North East Bright Ideas Awards in 2015. And if you want to hear more about the clinic, which is a really valuable vehicle for us to collect information and data and cohorts around fatigue and PoTS, then we have a publication in Health Expectations, which is a concept mapping study whereby we asked patients in the clinic what did they want from the service that we were providing and had quantitative responses with regard to that. In our clinic, in terms of managing patients, we try and avoid drugs if we can. What I've learned over time in patients with PoTS is that about half of them we start on tablets end up coming off them because the side effects of the tablets prove to be worse for them as an individual than having the PoTS itself. We take people off drugs that they may have been on for years, the tricyclics we've heard about, but lots of people come in on antihypertensives, etc. We recommend that people should avoid prolonged standing or sitting, heat, alcohol, etc., all the things that we've heard of earlier on today. And in terms of exercise, we are a multidisciplinary team that has a physio, psychologist, and occupational therapist working in the team, and our approach to exercise is very similar to that we've heard from Jane. Because this is a form of dysautonomia, in the PoTS group that we see in the clinic, we really do, as Nick said, push fluid. But we push fluid in everybody with fatigue, because I believe that fatigue is a symptomatic manifestation of low blood pressure. So we get people to practice counter manoeuvres. We encourage them to drink 2.5 litres of water a day and reduce the amount of caffeine that they're drinking. And it's really vital that you ask explicitly. And as I don't do 24-hour urine collections, but I may start doing now, because Nick's absolutely right that often people will come back and say, yes, I'm drinking enough water. And when you actually ask them how much is enough for them, it'll be 4 cups a day. So really making sure that you push home the message of 2.5 litres. We have in the past encouraged people to use tilt training. There's some evidence for tilt training in terms of being of value in fatigue and also in vasovagal syncope. If people are able to keep upright, it's a very good thing for them to do themselves and empowers them to do something about their condition. So tilt training, i.e. standing 15 centimetres away from the wall and effectively doing your own tilt test at home on a daily basis. As we've heard, there is no magic tablet, and I'm very frank with patients in clinic and explain to them that I have no magic bullet. This is a package of care, and that we have what we're trying to achieve is helping them turn a corner, and that they've been on a cycle downwards for a long period of time, and that if the package of care that we can help them with will help them turn that corner, they want the trajectory once they've turned it to be very steep, but the likelihood is that it will be a very low trajectory, and that over time we will get to know each other very well in the clinic. And as Nick says, I have no specific repertoire of medicines that are preferential. It is very much, are you an asthmatic? If you are, you can't have a beta blocker. Have you got low blood pressure? If you have, I will try fludrocortisone and midodrine. So it's very individualised. And in terms of going back to PoTS and CFS, and in terms of how bad it is, people will often say to me, well, when I've made the diagnosis of PoTS, does that mean I haven't got CFS anymore? And that's a really difficult question to answer. And people will say to me, does that mean that my condition's worse now because I've got PoTS, or is it better to have CFS? And I will be honest with people and say to them, there aren't many advantages of having either of these diagnoses, and I would swing it whichever way works for you, and I'll put both of them in the letter so that you can, if you are having problems with disbelief because you have the label of CFS, then perhaps the label of PoTS might be more helpful, and vice versa. We know that CFS is covered by the Disability Discrimination Act, and then for some people that is advantageous. So, I try not to be prescriptive with patients, and again, try and individualise for them. When we've looked in another study with PoTS UK at sending out symptom assessment questionnaires to people with PoTS and compared them to people with chronic fatigue syndrome, we sent out a whole range of different symptom assessment questionnaires and got a reasonable number back from patients. But the message from that study, which we have published, is that actually PoTS is a really horrid condition that gives you lots of symptoms which are as bad as chronic fatigue syndrome, if not worse. And that in terms of managing your symptoms, that's really lots of the approaches that we use in chronic fatigue syndrome may be of some benefit for managing symptoms in PoTS patients. So this is my last slide. In terms of PoTS in the UK, we know, as we've heard, that symptoms are very common in patients with PoTS and that fatigue is a particular problem in this patient group, and it's the symptoms that patients with PoTS experience is comparable to that with chronic fatigue syndrome, and chronic fatigue syndrome has dedicated services in the UK. They're not necessarily ideal, the services that there are in chronic fatigue syndrome, but the government invested £8 million in services and mandated that GPs must commission these services. So the system is very different if you're a patient with PoTS. CFS is recognised by the World Health Organisation as a neurological disorder, and that is sometimes valuable for patients in terms of belief. And what we need to do, in my view, is continue to promote the symptom burden and the significant comorbidity that occurs in patients with PoTS in order to get it as a condition similar recognition. And it's really important, in my view, meetings like this where like-minded people get together. This is fantastic. And if there were 30 people here last time this meeting was held and there's a room full of people this time, this is a movement that is growing, and I applaud PoTS UK for bringing everybody together, and I just hope that this momentum can keep going. And as always, when I'm in clinic, the most important thing that I do with my patients is point them to this website. Patients find this extremely valuable, and they also find it a vehicle by which they can realise that they can be believed and supported. So I use this as one of the best resources that I have. And that's just acknowledgement to say thank you to the funders for some of the fatigue work that we do in Newcastle. Thank you.